here for and I'll mostly focus on kind of the pain points from the pilot and what we did to improve those areas. And then, you know, if you have some more basic questions, maybe you can just kind of reach out to me afterwards, since, you know, this is really an hour-long presentation. We're going to squeeze it into 25 minutes. So I'm going to skip that because you guys know what that is. If you're like a workflow person, we have this Visio, but essentially it mirrors what you do for care management. You identify a patient that seems like a good fit. You talk to the patient about it. They agree that it's a good fit. You know, you order the stuff and you let Hugh know. And then, you know, Hugh will check in with the patient and make sure that they didn't have any problems, you know, getting their equipment. And as long as they're good to go, then he'll schedule an intake where he'll bring them in person. They'll talk through how to use the device, and then they'll set up a follow-up plan. So it's very similar to care management, right? You talk to a patient, you identify a patient, you consent them because care management is billed as well, right? And then you send, you know, the message to you. So let me spend some time on this because I think this was one of the kind of confusing points of the pilot. And there's a difference between eligibility, meaning they are medically appropriate for the program, and insurance coverage, right? So in my mind, like as I juggle lots of confusing things, I would put this in the category of, I would like to order Crestor for this patient because it's the best drug. However, there are some people who have insurances that are going to be like, no, like, I don't think we can cover it. Or maybe I need to choose a better example because Crestor is well covered now. Maybe I need to use like Nurtec. I want to order Nurtec for your migraine. So it's the same thing. Think about it like a prior auth for certain patients, okay? However, that doesn't mean that Nurtec's not a great choice for their migraines, right? So similarly, just because insurance isn't going to cover it doesn't mean it's not a good choice for their diabetes. So who would be benefit from CGM? So, you know, CGM is standard of care for type 1 diabetes now, and it's becoming more and more and more standard of care for type 2 diabetes. And if any of you guys attended the lightning rounds that I led with Savitha on Wednesday, you know, I think she really tried to emphasize that. Like, this is a really great tool, especially for patient engagement. I think classically we think diabetes on insulin. And sure, I'm sure there are a lot of people on insulin who would love to do this so they don't have to poke their finger, okay? But if you have someone who's really engaged in their diabetes care and wants to know, like, oh, what happens if I eat 3 slices of pizza rather than 2 slices of pizza? Or I don't really want to add on that additional medication, you know, if I don't have to, you know, this is a good option for those types of patients too. People that we would exclude from this program would be anyone receiving care from an endocrinologist. If they're interested in CGM, but they see endocrinology for their diabetes, they should talk to their endocrinologist. And I'm sure actually their endocrinologist probably already talked to them about it because endocrine is really using this. I mean, the DCC bills out 500 grand in CGM codes a month. So they're using it. We're not doing kids right now. And I think that's, you know, just because it's a new technology, developing field. We are not using it for gestational diabetes for those of us who do prenatal care. It is starting to be used more and more for gestational diabetes. You know, Savitha said it's not FDA approved yet actually for GDM, but a lot of people are using it. And we are not going to do the type 1 diabetics. Now, I know all of us probably have some type 1 diabetics that refuse to see endocrinology on our panels. For the sake of the support team infrastructure for this program, like namely Hugh having to support these patients, it's just too complicated right now as this is the infancy of us getting used to this technology, okay? So, you know, I'm really talking specifically about this program. Now, obviously all of you guys are professionals. You have someone that you want to do it for who's type 1, you can make that decision, but just don't, this whole program with like Hugh billing for the time and stuff is just not going to be the fit for that patient, okay? Now let's talk about insurance coverage. So insurance coverage for the equipment, which is mostly just the sensors, because most people these days, and especially if you fractionate off the people who would actually be interested in doing this, they usually have a smartphone. So For commercial insurance, you really just need any sort of diagnosis of diabetes. You don't even need to be on meds. And commercial insurers will pay for this. It gets confusing and more difficult with Medicare and Medicaid, which should not be surprising for us, right? And really for Medicare and Medicaid, you have to be on insulin and you have to have this added documentation of needing, TID insulin, needing frequent adjustments, needing to check your chem sticks like QID, et cetera. And I would say this is like a pretty big barrier, and hopefully will change as this becomes more and more standard of care. Let me just tell you, there are a lot of pathways to get these sensors at low cost though, and just avoid insurance altogether. Right now, actually, Libre has a coupon for 2 free sensors. Actually, I just had a patient who did this week. She's Medicaid and it's on type 2 diabetes. It has type 2 diabetes and does not want to add another med. So she just got 2 for free. So also, if you have patients who are willing to pay cash, they can usually find them for about $35 a sensor or $70 for 2. If you just use GoodRx, which I think all of us are very familiar with sending patients to, they can check and see which place has got the cheapest at the moment. And I think actually CVS and Target has the cheapest price right now. Just know that all the other codes that you bill, like the interpretation of the report, Q's time for downloading the stuff and doing teaching, all that has actually been well covered by all payers, including Medicare and Medicaid. And we have good claims data on that. It's really just those stupid sensors that can be the sticky wicket. So, get creative. I know we're all very creative with working with patients. Just know for compliance, there are a couple of things to do. And again, this really mirrors what we do for care management or consenting for BHIP. There's a generic RPM consent that you will need to blow in to some sort of encounter, whether that is a face-to-face visit or a telemedicine visit where you talk to patients about this and they agree, whether this is a telephone call or whether this is a back and forth, my chart conversation, just make sure that is in there. Additionally, there is a referral to RPM that you need to put in, and this actually puts the referral in Q's work queue. So he knows that you sent the patient there. It also helps us for compliance reasons, showing that you have ordered this program for the patient for billing purposes, and it helps us for tracking, numbers of patients that are enrolled. There is this dot phrase CGM RPM enrollment ABS, and you can put that in the patient's note from the visit. And you guys have this deck, and there's also a provider job aid, so you kind of reference that. But that basically tells the patient, it just has some nice patient-friendly language, like, you will be enrolled in this program. We will do this, this, and this. We will bill insurance. So it just has, some language confirming that they've decided to enroll. Ordering devices just like ordering a medication, except for Medicare, because Medicare, this is considered DME. So in your mind, these are Tedhos or Walker or something for Medicare. If you need to order them for Medicare, you can do 2 things. One, you can do that referral to DME and just type in like Libre in there. Or you can actually use the prescription, just print it for the patient, like you need to give this to a medical supply company. There is also this form that you have to fill out if you use the standard CGM tools, which again, there's a list of them. There's actually a link in the Epic Smart tool, so you can just click it out of your note and it will pull it. It also lives on the UW PC SharePoint site, the forms tab. You can also just print a couple in your inbox or something if you have Medicare patients, but you only need them for Medicare. Medicaid is just like a medication, so just like commercial. Let me just do a favor to Hugh. So most smartphones are compatible. If your patient has an ancient smartphone, like an iPhone 4 or something, the app, they may not make an app that's compatible with it. So if you are a little worried about their tech, just give Hugh a heads up and he'll, call them and make sure they have a device that's actually compatible. If they don't have one that's compatible, you can write them a prescription for this reader. But again, I think that's going to be really a minority of patients because probably your patients who don't have a smartphone that would be compatible are probably going to be like, I don't really want to do this anyways. Like, I don't know, give me some chem sticks and a book to write down in. This is just a screenshot of the Epic order for ordering stuff. We already kind of talked about this, but after you put in all your stuff, the referrals in, the supplies are ordered for the patient, Q will outreach to the patient and just be like, hey, did you get your sensor? Did you download the app? If all are positive, then let's schedule your intake. If the patient's like, I don't have a smartphone, or my insurance said no, or something, then he'll help you guys troubleshoot. But the more you can kind of prep for you, the better, because sometimes I think the nurses have called the patient and they're like, I didn't know my PCP was going to send me to this program, and then that's always not awesome for the nurse. And then so this is where we actually filled in some gaps in the workflow for those of you who tried it in the pilot. So now if they do have especially Medicare or Medicaid and they need this prior authorization with the DME form, chart notes, etc., the prior auth team will take care of this. So just like we've been kind of using them for other prior auths, they will take this and help kind of gather the stuff. There is some language that is in the standard SMART tools that helps document medical necessity, especially for like Medicare and Medicaid. So, just ensure that that's in your documentation so that when the prior auth team just prints your chart notes and sends them to Medicare, it has those things in it that they need to get it covered. That's why we built them into the dot phrases. In the intro meeting to the RN, with the RN, one feedback we got from the pilot is that initially the RNs were asked to do a lot of diabetic teaching, plus teaching a patient how to use a device. And that was just a lot to accomplish. So now the RN initial visits actually split into two, with the emphasis first on actually device teaching, because you need that to start the CGM program. And then potentially a second visit, if you have a patient who took like the whole hour to learn how to put the sensor on, sync it to their phone, etc., then the RN will book a second visit to do the diabetes teaching. If you've got a really tech savvy patient, they'll breeze through it. Like a lot of patients actually showed up to the meeting with you, like had already downloaded, had already tried it, and stuck the sensor on their arm. But some other people need more support, so it's a little bit more tailored this time. Let me just highlight this in yellow. This is from Tammy Wilson, your friendly neighborhood nurse. Please ensure that the care plan is relayed to the RN or RD who's going to be doing this, so they know what the heck you want the patient to do, like increase their meds or something. So they don't have to do this back and forth. Like, hey, Crystal, what did you want to do with that for a minute? I don't see it. I know. So just make sure you're sending that type of necessary information so they can help you. And then this is where it's very nice for us. This is a very provider-centric program, let me just tell you. All the other back stuff will be taken care of for you. So, Hugh will download the stuff from LibreView, put it in Epic, send you a message saying, hey, Lucy, your patient's report's here. He'll actually input the metrics into the notes. So if you don't have time to click and look at the report, they're actually literally there in the note, and all of that. And the nice thing is that time is global now, because that does take quite a bit of administrative time. So this is where we're hoping that success of programs like this could actually allow us to fund more support staff in the clinic, because typically RNs and RDs don't typically, bill out a lot of revenue. So this could be a way for us eventually, as we kind of transform the way we provide chronic disease management, to maybe have more nurses around or et cetera. This is new. So for those brave pilot people, we had a really bad workflow for documenting GMI and the other metrics. And now we have this IPD flow sheet. So the RN and RD will be putting the metrics in here, and so that is actually trendable. And then you can find it in here rather than having to click through notes. So if you go to the flow sheets and you type in diabetes MA, then this one will pop up. And you'll see that those columns highlighted in yellow, that is what you would trend. So you can see the GMI for 14 days, and the next GMI 14 days later, et cetera. You can track it that way. Okay. I'm not going to go through how to interpret an AGP report because I think you guys all attended to do this thing, and if you need a refresher, you can watch that again, or she does an abbreviated version in the lightning rounds that we did on Wednesday. But there's some good resources. I think this is really helpful as we just all kind of learn a new skill, just the quick steps. So number one, is there enough data? Is this at least 14 days? Because if it's less than 14 days, it's probably not enough data to change medications. For a reminder that the power of this tool is really patient engagement. So sitting together and interpreting with the patient is one of the things that would lead to most behavior change. Look at the pattern and identify like, okay, like what time did you eat? When did you take your meds? When do you go to sleep? So that you can interpret especially the glucose trends around activity. Look for patterns. I think Savita shared a really good example in the lightning rounds on Wednesday about someone who was, really needed prandial insulin because in the morning readings were normal, but as the day wore on, the glucose kind of rose. Put an action kit plan together, document it, and send it to Hugh, so he knows what you're up to. These are some other dot phrases. So what the RNs are going to be using, there's that standard dot phrase, the CGM RPM interpretation note that is got all the language so you can fill out the code for interpreting the report. And there's that IBS again. And then for in-between visit care, so you'll be getting, the fruit salad of different types of encounters that happen because of the basket, whether that's an e-care message or a TD, or even, God forbid, CC charts. Sometimes those will come, but we're kind of used to that. There's a billing coding grid. Really the big thing that you just need to remember is that second one is the 95251, and that is the interpretation. And you can only build that out once a month. So if you have someone who's going to be uploading 14 days, then you're only going to bill out one of the two. Epic is working on some better billing tracking tools for things like this, but we don't have them yet. So right now it's just kind of a manual recall of like, wait a minute, did I bill that last time? I don't know. I should bill it this time. Or, you can talk to Hugh. Like if you have someone who's not needing like frequent changes, you might want to only look at these like once a month. And then so this is the master job aid that has everything under the sun that we covered in this presentation. It has like a list of all the smart phrases. It actually has the text of the smart phrases too, if you want to take a look at them. And it's only 8 pages long. So, I mean, you guys could print this and just keep it like in your basket. Or you could just print the whole thing and just throw away all the ones that you don't need and keep the pages that are helpful for you. But this might be a good guide, just as you're getting used to this program. Here's the additional resources. So Savita's awesome and very detailed link to that presentation on interpretation. That's the link to the resources and job aids for CGM right there. And then Abbott actually has a really good provider centric training about interpretation of AGP reports. And I think that one's only about 13 minutes. So you guys can watch that. And this is just the list of all of the smart texts that are in Epic, and all of you guys should have them. If you can't find one of them, let me know. We've had some weird pockets of not have been shared with providers, but Nika can help you if you look for these and you can't find them. But they should be shared standardly with everyone in ambulatory. And I'll pause there with 5 minutes left. Any questions?
That SharePoint site,
Yeah.
how do you get to that?
Yeah, so there are a couple ways you can get to it. So that SharePoint site is actually the telehealth services internet site, which you guys should bookmark because aside from CGM, there's really important stuff on there like compliance stuff, like the interstate stuff, all of that is there. So if you go to, so you open up Internet Explorer, why we use that browser, I don't know. But is there, and then it's the UWPC SharePoint site, right? Because that's what it's sent to. If you look at the top left, there's like the there's links to like all the other medicine SharePoint sites. I don't know if you know that. If you click that, you can get to UWMC and Harborview and IT services. And so telehealth services has its own SharePoint site and CGM lives on that. Otherwise, there is a link from the UWPC SharePoint site. If you go to toolkits, there are, so the toolkits, what those are for the major primary care programs. So there's a digital health toolkit there, you can click it. And Ellen and Peggy Gannon are working on putting all these things or linking all these things from the telehealth services SharePoint site to PC SharePoint site. I think there's still a little bit in build, but I think they at least posted the CGM stuff on there. So that's a way. Otherwise, just pull it from the presentation and bookmark it in your browser.
So we're like, like the diabetes toolkit.
Yeah, so I can show you, actually.
Okay.
Oh, is it taking you? That's cool. Why isn't it looking to the UWPC? So. But when you guys open, it's this, right? There's actually a big picture of Peggy Gannon because she's the employee of the month. And so if you go to resources and toolkits right there, you will see digital health. And there's all of this kind of stuff here. There's actually telemedicine stuff on here as well as CGM. And okay, you did put it on here. So you see remote patient monitoring right there. So it's got all of the individual things. And then if you just, this one is the master job. Thank you.
Thanks.
Questions? So far,